speech. Dr. Ramesh Ramdani, President ISA NCP, NCB 24-25. Over to you, sir.
Thank you, Dr. Ki. First of all, good evening from ISA Nagpur. I welcome you all the delegates, speakers, presenters, PG students, and the teachers, moderators, and faculties of today's activity, Dr. Shakuntala, Madam, and Dr. Sugandh, sir. At the outset, I just want to inform that in my mind, when my president tenure started, in my mind, there was so much ideas to do something for PG students so that they should be well attached to the organization and they should feel interested in other activities, also academic activities and the cultural activities also. So PG activity is a very much important part of the curriculum of as far as MUH is concerned and NMC is concerned, our PG students teaching curriculum is concerned. So this activity is purely about the PG students, but definitely the young learners who are more interested in case management and discussions can also attend. So that's why we started this APT series. So academic practical teaching. The very first activity is today. There is on the ANC patient with mitral stenosis. So we have eminent moderators with us who will enlighten us about the intricacies of case discussion. This case can come into the long case for PG students in PG MD exam. Also, a long question can be asked on this. Even a short case can students can get. So ultimately, this is a very important topic. I hope that this topic will be more apt as the name suggests. So without much ado, I hand over the mic to Dr. Ketki and for further proceeding. Thank you.
Thank you, sir. So we have two eminent teachers, dedicated teachers with us today to guide us on this topic as moderators, Dr. Shakuntala Basantwani ma'am and Dr. Ramesh Sugandh sir. Dr. Shakuntala Basantwani ma'am is an additional professor at Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. She is also guide for fellowship in cardiovascular anesthesia. Madam has many publications to her credit. The second teacher with us is Dr. Ramesh Sugandh sir. He is an associate professor at GMCH. Sir has many publications to his credit and both are extremely dedicated teachers and they'll guide us today on this topic. So the presenters for today's topic are Dr. Himani Shrivastava and Dr. Harshali Wankhade. Both are third year MD residents from Department of Anesthesia, GMCH. So if our teachers permit, we'll start the presentation. First, Dr. Himani Shrivastava will start the presentation. So I'll stop sharing and then she can start the PPT.
Yes, we can proceed.
All please mute yourself except moderators and presenters. All others please mute yourself. Ketki, you can mute others.
Yes, sir. One more time, requesting all the members to kindly mute yourself so that there would be no interruptions or no disturbance while presenting the presentation by the students.
आर्थिक पेशंट जे राहिले तर बायोमॅल्युलर फ्रॅक्चर आहे ना त्याचं प्रोसिजर वापस काय करणार आहे तर ऑपरेटेड झालेलं ना तो वापस ओरिफ करायचे का
I request all the members to kindly check your microphone and kindly mute yourself.
आणि पहिले ते रिमूव्ह करून
Himani?
Good evening, ma'am. Yes, ma'am.
Yes, start your presentation, please.
Yes, ma'am. Good evening, everyone. This is Dr. Himani. I am presenting my topic with pregnancy with mitral stenosis. I and my colleague, Dr. Harshali, will present this topic. Starting with the presentation.
Ethiopia.
My case is a 22-year-old
Just a
primary care
moment.
with a
Just a
female.
moment. Ketki, you can mute the person who is.
Yes, sir. That is what I'm checking with that person.
Okay. Okay, continue, Dr. Himani, continue.
Okay, sir. My case is of a 22-year-old primary care with a female, housewife by occupation, who came into casualty with labor pains at full term. Her chief complaints was she presented in the casualty with labor pain since last half an hour. The breathlessness was present since last 1 month, which was exacerbated in last 10 days. History of present illness. My patient was apparently all right 10 days back, after which she started complaining of breathlessness, which was gradually progressive, exertional, and grade 3 in severity, according to the NYHA grading. The breathlessness was not associated with cough or fever. There was no history of chest pain, palpitation, and there was no history of swelling of legs. And there was no history of syncope. Patient had history of rheumatic fever in her childhood, which mainly affected her large joints, like the ankle joint, the knee joint, elbow joint, after the episode of sore throat. And the arthritis was fleeting in nature and was not associated with any skin abnormalities or abnormal movements. She was diagnosed with rheumatic heart disease with mitral stenosis 2 years back and was started on tablet metoprolol 25 mg OD and tablet furosemide 20 mg BD. Patient had no history of hypertension, diabetes, thyroid disorder, asthma, TB, sickle cell, or thalassemia. There was no history of any prior surgery, blood transfusion, or any ICU admission. There was no history of any drug allergy. Her effort tolerance was one flight of stairs, and patient denied any history of addiction. In the general examination, my patient was conscious.
Himani, just a minute. See,
Yes,
from your history, we can't make out anything because lots of points you have missed out. You have only taken negative history of cough, cold, fever, chest pain, palpitation. Other symptoms of right ventricular failure you have not covered. Okay, you have not covered the symptoms suggestive of left ventricular failure, right? And many symptoms you have not covered. So I think you should cover all the symptoms so that we can come to know what exactly the patient is, because patient is not in front of us. So history should tell us exactly what is the picture, whether she is a right ventricular failure, whether she is a left ventricular failure, has she any history of hemoptysis. All history you should include. Many histories means you have not covered, right? So next time in the exam, please cover all those points, right?
Yes,
Yeah.
Yes,
Okay. Go ahead.
In the general examination, my patient was conscious, cooperative, and oriented. Her build was average. She was afebrile. She had mild pale. She had mild pallor. Icterus, cyanosis, clubbing, lymphadenopathy, all were absent. Her pulse was 69 beats per minute, which was regular, normovolemic, with no radial delay. Her BP was 122 by 76 mmHg in sitting position. Her saturation was 99% on room air. In her previous exam.
Hello, Dr. Himani. Dr. Himani, just a minute.
Yes,
You
sir.
have mentioned pulse 69 beats per minute is low volume or high volume. What do you want?
Normovolemic, sir.
It's a normal, it's not expected in mitral stenosis patient.
Yes, sir. In mitral stenosis patient, there is usually low volumic icterus.
That too in your patient is pregnant, in which there already hemodynamic changes are there, you know.
Yes, sir.
And also, apart from radial delay, there should also be mention about the apex pulse deficit,
Yes, sir.
so that you can know that your patient is not suffering from any atrial fibrillation. Your NYHA class 3 is their patient.
Yes, sir.
So these points we have to cover in examination also.
Okay, sir. Yes, sir.
And also, if you want your patient to put intra-aortic intra-arterial monitoring, for that you have also C for the Allen's test. No?
Yes, sir. Yes, sir.
Okay, go ahead.
In her cardiovascular examination in inspection, there was no deformity or bulging present. Apical impulses were present. There was no engorged or dilated vein seen. No scar mark was present. In palpation, apex beat was felt in the fifth intercostal space in the mid-clavicular line. There was diastolic thrill present in the mitral area. In auscultation, S1 was short and sharp, and P2 sound was loud. There was also a low-pitched mid-diastolic rumbling murmur heard, which was best heard with the bell of the stethoscope in the left lateral decubitus position.
And
In the
also the
respiratory
murmur is best heard in expiration. No?
expiration, yes, sir.
Yeah, that point should be, we have to add.
Okay, sir. In the respiratory system, her breath sounds were vesicular. There was no adventitious sound heard. In the abdominal examination, her abdomen was soft, it was non-tender, and the fundal height was still 36 weeks of gestation. There was no lump or fluid shift. In the airway examination, we examined the mouth opening, which was more than 3 fingers. Her Malampati grading was 1, and the neck circumference was 34 centimeter, and the sternomental distance was about 14 centimeter. In the after the pre-anesthetic evaluation, we advised her complete blood count, liver function test, renal function test, her prothrombin INR type, the serum electrolytes, ECG, 2D echo, and we asked for the high-risk consent.
Your examination is complete. You have not mentioned about the CNS or
Yeah.
peripheral pulsations were present or not.
Even in
Is
general examination, you have missed lots of points, Himani.
Yes, ma'am.
See, whatever is not present, because now you know your patient has got MS, right? So,
Yes, ma'am.
mitral facies was present or not, that everything, and ascites, many points were missed. JVP was raised or not, that also you have not included with the
or hepatojugular reflex is present or not.
add those points, right?
Okay, ma'am. Yes, ma'am.
Go ahead.
I'll begin with the
Now,
etiology.
no, just wait. Now, first of all, what all advices you have given? Show me. Go to the previous slide. Okay. Now you tell me, what will you get in the blood count? Why you have advised blood count?
Ma'am, I have advised the blood count for knowing the hemoglobin of the patient. Since
What will happen to the hemoglobin? Is before you go to the pathophysiology, let me know whether what will happen to the hemoglobin.
Yes, ma'am.
Why you want to know the hemoglobin?
Ma'am, most of the pregnant females are associated with anemia. So we have to know the hemoglobin of the patient. We also need to know the hematocrit of the patient. Since the blood volume in pregnancy, it increases by about 30 to 40% in the patient.
Any other reason?
I will also ask for the leukocyte count and also for the platelet count also.
Why do you want to know the hemoglobin? And in the examination, you said build was moderate, no? You
Yes,
written
ma'am.
the build was moderate.
Yes,
Was
ma'am.
she moderately built? How are the MS mitral stenotic patients?
Ma'am, mitral stenotic patients are usually thin built.
Yes, they are thin built. What is the reason behind that?
Ma'am, because of the cardiac output is usually decreased in mitral stenotic patients.
Correct. And then?
Ma'am, sometimes because of there can be swelling in the lower limbs of the patient because of the right heart failure. If it is associated with the right heart failure, then it could lead to the edema also.
No, because in patients with mitral stenosis, because of reduction in the cardiac output, even the GI blood flow is reduced. Okay, and because of that, their appetite is reduced. So they eat very less. Understood. So because of that, they don't gain weight. Their hemoglobin is always on the lower side. They are cachexic. So this point you should know. Okay. Any other investigation?
Yes, ma'am. I'll ask for the liver function test, the renal function test,
Yeah.
for the PTINR, serum electrolytes, ECG, 2D4, and for high risk.
Okay, we will discuss one after that. Okay, go ahead.
Shall I begin with the etiology?
Yes. Go ahead. Go ahead.
The etiology of mitral stenosis. Mitral stenosis is usually associated with rheumatic heart disease in most of the developing countries. Rarely, it can also be associated with congenital heart disease, systemic lupus erythematosus, carcinoid syndrome. Also, it can also be associated with Hunter's disease, Hurler's disease, Fabry's disease, and Whipple syndrome also. Pure mitral stenosis is seen in
Now
40%.
here your patient has got MS in pregnancy. So what happens in pregnancy which make you diagnose MS?
Ma'am, because the patient becomes very breathless.
Hmm.
Like breathlessness is seen in the patient, and also
Means how will you differentiate between the normal pregnancy and heart disease in the pregnancy?
ma'am, we can start from by the history taking. In the
Right.
history taking, the patient will have breathlessness. The dyspnea, it could be from NYHA grade 1 to 4. Mostly in the female pregnant patient, she will present with NYHA grade more than 2.
Right.
And
What is the reason?
other
What is the cause for that?
and because of the decrease in cardiac output, it can cause breathlessness.
No,
Moreover, it
What I am asking, how will you differentiate a normal pregnant patient from a patient of mitral stenosis? Because normal pregnancy also mimic like heart disease, right? So,
yes, ma'am.
So what are the causes? What is the etiology that even pregnant patients have symptoms of this heart disease?
Like the normal pregnant patient.
Yes, normal pregnant patient.
Uh,
Because
ma'am,
this etiology of MS, वगैरह, that is not very important, right? Because we are presenting pregnancy and MS, right? So tell me.
and the cardiac output in pregnancy increases by 30 to 40%. The heart rate also increases by about 25%. The stroke volume also increases by 25 to 30% in a pregnant female. And also the blood volume increases. The oxygen demand, oxygen consumption also increases by 40%.
Correct. So because of all these things, the patient may present. This normal pregnant patient can also get breathlessness. Correct?
Yes, ma'am. Yes, ma'am.
And then on examination, what all things you get in patient which mimic like heart disease? Normal pregnant patient.
In the examination, ma'am, she will be pale.
Correct.
In general examination, she will be pale. Ma'am, edema can also be seen in a pregnancy.
So patients can have edema, right? Then
Yes,
which
ma'am.
other thing they can have which looks like cardiac disease?
Ma'am, she like anemic pregnant patient will also have a murmur present.
Yes, murmur. So all these things, they look like that the patient has got heart disease. So actually, what are the features which suggest that this patient is really having heart disease? Differentiating features.
Yes, ma'am. And the dyspnea, it could also be orthopnea. Orthopnea can also be present in a mitral stenosis patient. And paroxysmal nocturnal dyspnea will also be present in a mitral stenotic patient. Along with that, chest pain. If the patient is in if there is increase in the pulmonary arterial pressure, then hemoptysis will be present in the patient. If the patient has associated cardiac failure, then cough cough will be present. A generalized anasarca can be present. Abdominal distension with ascites can be present in the patient.
So usually pregnant patient, they have systolic murmur, right? If the patient is having diastolic murmur,
it is in
correct, or any audible fourth heart sound, then in those patients you should suspect heart disease, and all the symptoms are not because of pregnancy, it is because of heart disease. Okay.
And
Go
also,
ahead.
also one point is you can palpate the systolic thrill
Yes.
or
Yes.
diastolic thrill. And one
Yes.
more point is the pregnant patient is having no low oncotic pressure is there. So again, they are more prone for pulmonary edema, and that case risk is increased in the presence of mitral stenosis because of increased hydrostatic pressure.
Okay, sir.
Now you tell me, in pregnancy, why mitral stenosis is poorly tolerated? What are the features which are present in pregnancy which we don't require in mitral stenosis?
Ma'am, in pregnancy there is tachycardia. The heart
Very
rate increases. So, because of the tachycardia, the diastolic filling, like the diastolic time is decreased. So the left ventricular filling is decreased. And since the left ventricle depends on the atrial kick, left
Correct.
ventricle filling depends on the atrial kick. So because of the shortening of the diastolic period, the cardiac output, the left ventricular filling won't be appropriate, and the cardiac output will be decreased in those patients.
Correct. Any other finding?
Ma'am, because of the increase in the cardiac output also increases, since it increases by 30 to 40%. The
Correct.
transvalvular pressure gradient, which is according to the Godlin's formula, if it is square times increase of the cardiac output, so the transvalvular pressure gradient also increases, further leading to the pulmonary venous hypertension, pulmonary venous, then pulmonary arterial hypertension, and then pulmonary edema.
Correct. Any other
Since the
thing?
blood, yes, ma'am, the blood volume also increases.
Very good.
So because of the increase in the blood volume by 30 to 40%, it can cause the rise in the hydrostatic pressure, which can lead to pulmonary edema. Other things which can, pregnancy is also an hypercoagulable state.
Correct.
So it can increase the episodes of thromboembolism.
Yeah. Now go ahead with pathophysiology.
One more question, at which stage the pregnant patient is more prone for cardiac failure?
Sir, at the time of the delivery, and also at the time peripartum period. Sir. Peripartum period is the most is more like the patient is more prone for.
And during pregnancy, which gestational age they are prone for going into failure? Not only during pregnancy they go in failure, they go before that also, and because of that they can get admitted, right? So which is that period?
Ma'am, after the first trimester, when the cardiac
Yes, after the first trimester. Yes. So by 24 weeks, they can go into failure, right?
Yes,
Yeah.
ma'am.
Now you
Or
explain everybody. Go ahead.
Dr. Himani, why you are saying that postpartum period is more dangerous?
Yes, sir. Because, sir, in the like during the delivery, the cardiac output increases by about 75%, and after the removal of the placenta, there is auto transfusion, which increases
Yes,
the preload in the body.
yes.
Yes,
And
sir.
also there is, the compression over the IVC and aorta is also relieved.
Also
So
relief.
there's
So yes, sir.
sudden gush
Decompensation
of
to the
blood.
thing.
So there is sudden gush of blood which increases the preload. And since it's a fixed stenotic lesion, so patient will end up with failure. So how will you prevent this at that time?
So we can prevent all of these things. So we can prevent the tachycardia at the time which happens by giving epidural analgesia to these patients.
You
Don't
have
go
also
there. Don't go there now, right? Just what is the treatment of failure? Because patient has not come to you till now. The patient has been admitted in EMR with failure. So what is the management?
Okay.
Anesthesia part we will discuss later on.
Yes, ma'am. First, we'll give ma'am 100% oxygen to the patient. We can give 100% and 100% oxygen to the patient. The tachycardia, which she presents, we will give the diuretics to the patient.
yes, yes,
That is the mainstay, right?
Oh,
Okay.
good. Go ahead.
Go ahead now. You explain the pathophysiology now. What are the after effects of mitral stenosis all over the body? Yeah, go ahead.
Okay, the pathophysiology. Ma'am, the mitral stenosis leads to the obstruction to the left atrial empty, which causes the increase in the left atrial pressure which causes the increase in the left atrial size. The increased left atrial pressure causes the rise in the pulmonary venous pressure, which further leads to rise in the pulmonary arterial pressure, which ultimately leads to pulmonary hypertension, which leads to right ventricular overload followed by right ventricular hypertrophy and tricuspid regurgitation. The increase in pulmonary venous pressure also leads to pulmonary edema, pulmonary arteriolar constriction, which leads to decrease in the lung compliance and increase in the work of breathing. Because of the obstruction of the left atrial emptying, it leads to decrease in the left ventricular filling also, which ultimately leads to a decrease in cardiac output.
What is the cause of persistent pulmonary hypertension in these patients? See, initially, just because of pulmonary venous hypertension, just because of back pressure changes, the patient gets pulmonary arterial hypertension. That is reversible. Okay.
Yes, ma'am.
Now, what is the cause of persistent pulmonary hypertension? Means after a certain stage, it becomes very difficult. You have to administer pulmonary vasodilators like sildenafil, Basantwani, and all those things, right? So, but what is the cause?
Ma'am, because of the arteriolar constriction.
Then occurs secondary to?
Persistent rise in the left atrial pressure. If it is more than 25 mmHg, it leads to a constriction of the pulmonary arterioles, which leads to secondary reactionary pulmonary hypertension, which is irreversible.
It occurs because of the passage of that fluid into the alveolar walls, right?
Okay.
And these alveolar walls, then they become fibrosed, and it becomes very difficult to correct that after certain point. That is known as what? Jordan's hypothesis. Okay? Yeah. Go ahead.
These are the consequences of the mitral stenosis in the left atrium. Since there is a decreased flow of the blood from the left atrium to the left ventricle due to the stenosis,
Slides are visible. Our slides are visible.
Yes, yes.
Yeah.
I am not able to.
No. Her slides are very.
No, it's visible.
Yeah.
Okay.
Because of the stenosis, there is stasis of the blood leading to the left atrial thrombus formation, and also there is increase in the left atrial pressure, which leads to left atrial dilatation, which can further lead to atrial fibrillation. There is increase in the pressure gradient between the left atrium and the left ventricle in the diastolic period, which further leads to increase in the pulmonary venous pressure, pulmonary capillary pressure, pulmonary arterial pressure, and further leading to pulmonary hypertension. Also, there is the increased risk of pulmonary edema. In the right ventricle, since there is persistently elevated pulmonary arterial pressure, it leads to pulmonary hypertension, which causes increase in the right ventricular afterload, further leading to right ventricular hypertrophy, leading to right heart failure, tricuspid regurgitation, right atrial enlargement, and which leads to hepatic congestion.
And this can give rise to liver dysfunction.
Liver
right?
disease.
And
Yes.
alteration in the liver function test. That is why doing LFTs are very important. Okay.
Yes, ma'am. In the left ventricle filling decreases due to the stenosis. So the left ventricle depends on atrial kick for the ventricular filling. Thus, if the heart rate increases as it is seen in the pregnancy, the diastolic fluid decreases, decreasing the left ventricular filling. The left ventricular filling also decreases in atrial fibrillation.
Dr. Himani, thus in normal patients, left atrial kick is important for left
So I
ventricle
couldn't
filling.
hear you.
There is lots
Hello?
of disturbance.
I request everyone to please mute yourself. I request everyone to please mute until and moderators and case presenters. Please mute yourself.
Dr. Himani,
Yes, sir.
Dr. Himani, thus in normal patients, atrial kick is important for left ventricular filling, or it is
Yes,
only the
sir.
mitral?
No, sir. It is important even in the normal patient. It contributes to about 25%.
Only 25%. So not in normal patients. It's important
Yes.
for
In the patient
stenotic
with
patient.
stenotic valves. Yeah. Yes, sir.
Stenotic patient.
Yes, sir.
Okay.
I think this we discussed. Pregnancy-induced changes you have already told. Right?
Yes. Yes, sir.
Go
Yes, sir.
ahead now.
Now, this is the NYHA classification for heart disease. Class 1 is asymptomatic patient except during the severe exhaustion.
Your patient is 3, class 3.
3, yes, sir.
Class 3.
Oh,
Okay. Now you tell me, how will you classify heart disease or mitral stenosis? Which grade? How will you classify the risk factors or risk stratification in pregnancy, in patients with heart disease in pregnancy? How is it classified?
Ma'am, there can be two classifications for classifying the patient. It could be Carpret score. We can use Carpret score for the classification. The Carpret score consists of 10 predictors, ma'am. First predictor is if the patient has previous cardiac episodes like TIA, heart failure, or arrhythmia, then it is classified. It is given 3 points. If the patient is of NYHA grade 3 or 4, then also 3 points are given. If the patient has mechanical well, then 3 points are given. Other than that, if the patient has ventricular dysfunction, pulmonary hypertension, coronary artery disease, or high risk aortopathy, or left ventricular outflow obstruction, all these are given 2 points each.
Correct. Now your patient is at NYHA class 3.
So we'll give 3 points.
You will give 3 points. So what is the, accordingly, how much is the morbidity, mortality you are expecting?
Yes, ma'am. So it according to the percentage wise, ma'am. If the patient has a score of 1, then the risk is only 5%. But since my patient is has 3 points, her risk is about 22%.
About 22%. Correct. So accordingly, we are supposed to explain to the patient or relatives that this much is the risk. Now, patient has come to you at 9 months gestation, right?
Yes, ma'am.
9 months. She has come for the first time to us. Correct?
Yes,
she was not ANC registered with us. Correct?
Yes,
am I right?
Yes,
and she has got NYHA class 3. She is not in atrial fibrillation.
Yes.
Correct. So how will you investigate the patient? First, hemogram you have told me, right? Then what other investigations you will do and what you are expecting?
Okay. Hemoglobin, it would be like hemoglobin will be less.
It is done. It is done. Go ahead. Next point.
Yes, ma'am.
Which other investigation you will ask?
Then I'll look for the liver function test, which could be deranged. The bilirubin will be less, and the
but your patient doesn't have. You have not mentioned in your history that patient has right ventricular failure, right?
Yes, yes, she doesn't.
But she has mentioned diastolic thrill is present.
Yeah, diastolic thrill is present, but she doesn't have liver dysfunction, no? Means edema feet is not there. She doesn't have tender hepatomegaly. Hepatojugular reflux is not positive. She's not having icterus.
Yeah.
Okay. Now go ahead.
Yes, sir. Then I'll ask for the RFTs also for the renal function test. In the renal function test, ma'am, like if there is right ventricular failure, then it can also cause a decrease in the urine output, which can increase the creatinine levels also. So I'll check for the RFT in that patient. I'll check for the INR since the patient patient was earlier diagnosed of mitral stenosis. So I'll ask for the history of anticoagulants, if she's taking any anticoagulant, and also I'll ask for the PTNR.
What are the indications of anticoagulation in patients with mitral stenosis? All patients are not put on anticoagulation.
Yes, ma'am. Ma'am, if the patient has prosthetic valve, then we give. If the patient have
directly prosthetic valve, your patient has presented for the first time, no? So she doesn't have any history of prosthetic valve.
Yes,
what are the indications? What are the indications of anticoagulation?
Yes, ma'am. If she has left atrial thrombus, if she has history of atrial fibrillation or any other thromboembolic episodes, then we will give anticoagulants to that patient.
Also, if there is history of peripheral embolization in the past, then also there is risk for anticoagulant. Yes, indication for anticoagulant.
Yes, sir.
Now, which anticoagulant is preferred in pregnant patients?
Ma'am, in the first trimester of the pregnancy, heparin is recommended. For the second trimester and the third trimester, warfarin is recommended to the patient. But just before the delivery, the patient should stop warfarin and should be started on bridging unfractionated heparin therapy.
Correct. Now go ahead.
Symptoms which are usually seen in the
No,
patient.
symptoms. nahi. We were on the investigation.
Yes, sir. Sorry.
Yeah.
Then we'll ask for the ECG of the patient. So in the ECG, there are characteristic ECG changes. There will be bifid appearance of the P wave, which is seen.
So the ECG, you have ECG?
Yes.
Mitral stenosis, show the ECG. Yeah.
There will be bifid P waves, ma'am.
Which lead you will get bifid?
It is classical. It is typically seen in lead 2, 3, and ABS.
Correct. But in this ECG, it is not seen, right? Bifid P wave.
What does it mean, bifid P wave?
Sir, because of the left atrial dilatation, it can cause bifid the impulses.
So initial upstroke is because of initial bifid you said. So initial upstroke is because of
atrial
contraction of which atrial contraction? Pacemaker is present in which atrium? Pacemaker is present in which atrium?
Right atrium. Right atrium.
So initial kick is because of right atrium. Then the next kick is because of left atrium as
left
it is
atrium. Yes, sir.
Otherwise, there is synchronized contraction of LA and RA. You don't get bifid fever in every patient. Okay, here you get because of left atrial, right atrial, and then left atrial. Okay, which other characteristic finding you will get in ECG?
Ma'am, we can get right ventricular hypertrophy can be seen in the patient.
In the P waves.
In the P wave, which other abnormality?
Atrial fibrillation, the P waves will be absent.
Any other abnormality you will get in P wave? You will get tall peaked P wave in patients with pulmonary hypertension.
P mitral.
That is called P mitral. No, P mitral is that's it. You will get tall P. That is called as P pulmonale. You will get P pulmonale if the patient has got pulmonary hypertension. Right? Okay. Next finding.
Next finding is right ventricular hypertrophy can be seen in the patient.
Correct.
Then
how will you diagnose right ventricular hypertrophy?
Right ventricular hypertrophy can be detected by we will see the chest leads in the V1 lead the R wave will be prominent and in the V6 lead the S wave will be prominent.
Correct. Very good. Any other finding you will get?
Right axis deviation will be seen.
Correct. Right. Any other thing? You can get right ventricular strain pattern.
Okay.
Right ventricular strain pattern can also be seen. Okay. Next, which investigation?
Then we'll do the 2D echo.
Correct. X-ray test we will not do because she is pregnant.
Yes.
But you should know the characteristic finding of mitral stenosis in X-ray test, right?
Yes.
Okay. 2D echo. What are things you will look for? What are things are important for us as an anesthesiologist?
Yes, sir. I'll look for the ejection fraction of the patient, ma'am.
Ejection fraction is not that important in MS patients, right?
Okay. Then ma'am, I'll look for the mitral valve area of that patient.
Correct.
Then I'll ask for the transvalvular pressure gradient.
How will you classify later on? You tell me. Yeah?
Yes, ma'am. I'll ask for the pulmonary arterial hypertension. Like what is the range? Then I'll also ask for other valvular abnormalities like regurgitation, if it is whether it was associated with regurgitation or other stenotic lesion will be present. I'll ask for the thrombus if any thrombus is present.
Okay.
Also,
other than that, mitral cusp, whether it is calcified.
Yes.
That is very important. That is very important. that is calcified. Any other thing? You will see Wilkins score basically.
Yes, ma'am. Wilkins score. Yes,
Can you show the slide for Wilkins score? Have you made Wilkins score slide?
No, ma'am. I have not put Wilkins score slide in it, but
Okay,
I have
Why
made it.
why it is important?
Sir, it tells about the prognosis after doing percutaneous balloon
no,
valvular.
it decides the management basically.
Okay, ma'am.
Yeah,
Okay.
because if calcification is there, subvalvular fusion,
Thickening.
fibrosis, thickening, everything. So management depends on that, right? Now your patient has come at 9 months in normal sinus rhythm, and according to you in 2D echo, what is the finding in 2D echo?
Ma'am, her ejection fraction was normal. It was about
Show the
actually.
echo. Show your echo.
Ma'am, these are the echo findings which we can see in the patient.
Okay. So how much was the gradient across the mitral wall?
Ma'am, the gradient was 8 mm of Hg.
Okay. And how much was the valve area?
1.4 centimeters square.
1.4. Okay. And Wilkins score was, how much was the Wilkins score?
Ma'am, Wilkins score, actually, I have not calculated the Wilkins score of that patient.
Okay. And calcification, nothing was written.
No calcification or any thrombus.
Okay.
Any vegetations?
Yeah.
No, sir, there was no evidence of
No.
vegetation.
Now this patient has come. What is obstetrician? What they want to do now? They want to post the patient for vaginal delivery or LSCS?
Ma'am, the obstetrician wants the patient to post it in vaginal delivery, but ma'am, since the patient is of NYHA grade 3, will prefer LSCS to that.
But that is not our choice. That obstetrician has to decide whether they want to go ahead. Is there any obstetric indication for LSCS?
No, ma'am. Currently, the patient and the fetus does not have any indication.
Does not have. So now suppose this patient is coming to you. The patient is fully investigated. You know the NYHA classification and they want to go ahead with vaginal delivery. So what is our role?
And first, there is a multidisciplinary approach is created between an obstetrician, cardiologist, and an anesthesiologist. So, so they decide.
One more person is there, no? Neonatologist.
Neonatologist.
He should be there, right? Okay. Go ahead.
So we'll assess the risk benefit of every mode. If the obstetrician wants to undergo vaginal delivery of the patient, then we'll give epidural analgesia to that patient.
You will give labor analgesia.
Labor analgesia, yes, ma'am.
And your patient is not on any anticoagulants.
No, she is not on any.
Not on any anticoagulant. Okay. How will you go ahead with labor analgesia? Tell us.
Ma'am, for the labor analgesia, first we'll obtain.
First you tell us what are the goals. Anesthesia goals in patients with MS.
Anesthesia goals in the patient of MS is, ma'am. First, we have to reduce the tachycardia of the patient.
Correct. So control the heart rate.
Yes, ma'am. Control the heart rate. If the patient is on diuretic, then we also have to maintain the preload of the patient.
Correct.
Maintain the systemic vascular resistance also, which is usually decreased in pregnancy because of prostaglandins or progesterone. Then we also need to do all the hemodynamic monitoring of the patient. So even while giving the epidural analgesia, we should put intra-arterial catheter for arterial monitoring of the patient. Since the patient is of NYHA grade 3, we should maintain, we should decrease the pulmonary vascular resistance, which should also not increase.
Correct. Very good. And what other thing you should not allow? very important thing, which we
Anxiety.
always do. No, that is also okay. Which we always do prior to giving regional anesthesia. We always
decreasing
say,
systemic vascular resistance.
we always say na, अरे preload करो patient को load करो, co-loading. Co-loading concept is there, na? So you are not
Yes,
supposed to give too much of fluids to the patient, but at the same time we have to maintain the intravascular volume, right? And okay, now you go ahead. At what level, what all things you will give? Tell us.
Yes, ma'am. I'll start with giving epidural analgesia to the patient. I'll prefer giving her analgesia in a lateral position to the patient. I'll start with giving bupivacaine drug. Low
At
dose
what level you will put? At what all nerves you will block?
Yes, ma'am. Ma'am, since it is only for analgesia to the patient, I'll block. Ma'am, the analgesia required is from T4 level, T4 to T6 level, and up till
T4
L1.
level, labor analgesia.
Patient is in labor in first stage or second stage, suppose.
In the second, sir, in the second stage, I'll start preferring putting this epidural catheter in the first stage only.
Okay, first stage.
At that, which nerves do you want to block?
Sir, I'll block the nerves from T10.
Yes, T10.
So from T10 to L1.
Yes.
Okay, so where you will put the catheter and what drug you will give?
Ma'am, I'll place the catheter at the at level of T12 vertebra. And I'll give this bupivacaine at 0.0625% concentration of bupivacaine will be given to the patient. And
how will you test the epidural catheter that it is in the epidural space?
Yes, sir. I'll avoid using epinephrine to this patient for testing. I can use opioid like fentanyl can be given for testing the patient for testing whether the catheter is in epidural space.
How will you know that?
Sir, if the yes, sir, if the opioid is given in the subarachnoid space, then the BP and the heart rate both will fall down.
What about neurological status?
Yes, the patient will be drowsy also.
No, by giving test dose, you will rule out intrathecal or intravascular, right? So
Yes,
by
sir.
giving lignocaine 1.5% slowly, you can rule out intrathecal if there is sudden hypotension and there is sudden the level of dermatome reached up to T6, T8, and also this hypotension. And plus, if it is intravascular, then there will be perioral numbness will be there. No?
Yes, sir. Yes, sir.
And
Yes,
metallic taste will be there. And you will give epidural analgesia, labor analgesia incrementally, not just you give 10 ml or 8 ml. You have to give in increment doses, judicially observing the intrathecal or intravascular.
Yes, sir.
So how will
you
you
are giving labor analgesia? Intraoperatively, patient goes into hypotension. What will you do?
Ma'am, small boluses of phenylephrine can be given.
How does phenylephrine act?
Ma'am, phenylephrine is an alpha agonist drug.
Okay.
Ma'am, it is sympathomimetic drug, which increases cardiac contraction, means myocardial contractility without increasing heart rate. So it is beneficial
in patients with MS. That is what we don't want to increase any heart rate. So phenylephrine is a good choice compared to ephedrine or methylphenidramine or whatever is to be used. Now,
Yes.
suppose this patient comes in emergency, right? There is some fetal distress or something like that, and she comes in emergency. She comes for emergency LSCS. What will be our plan of anesthesia? Because now we cannot go ahead with labor anesthesia, or we cannot go ahead with epidural anesthesia. Okay, and epidural is not yet put. She directly comes into emergency for LSCS. What will be our role or plan?
Plan of anesthesia will be general anesthesia, ma'am. First, I have to rule out if she is on any anticoagulants. I have to make sure she is having adequate duration from last dose till the induction. If she, then firstly, I will prepare every pregnant patient. I will consider as non-NBM and go according to that rapid sequence induction, modified rapid sequence induction. I will give pre-medication according to that. Then I will make sure my emergency drugs, cardiac drugs, and airway trolley is ready. After pre-medication, then give induction, rapid sequence induction.
Prior to giving pre-medication, will you take care of something? You will put wedge under.
Yes, ma'am.
Aortocable compression has to be prevented. Right?
Yes.
Okay. Go ahead.
Then multipara monitors I will attach, and if possible, CVP line and arterial line should be put. Then after induction.
How will you induce?
Induction.
How will you induce this?
After pre-oxygenation, and then induction with, I will prefer intermediate injection, intermediate 0.2 mg per kg.
Now again you talk about the goals, no? Now suppose patient has come with heart rate of 180. How will you do the case? Because of labor pains, her heart rate has increased. And she is in fetal distress. Okay, how will you go ahead? Himani?
First,
your main goal is
to avoid tachycardia.
Correct.
So what you will do?
For heart rate control, we can give, if she is hemodynamically stable, then we can give pharmacological treatment like metoprolol 5 mg IV bolus, ismolol, like beta blockers, metoprolol and ismolol.
Any other thing you can do if the heart rate is not getting control with your esmolol, metoprolol? Which other drugs are preferred?
Yes, ma'am. Diltiazem, digoxin, then last option will be amiodarone. Before that also I can give.
Now if the patient is hemodynamically unstable,
then I will go for cardioversion, ma'am. Sedate the patient and cardioversion with 120 to 360 joule by physics.
And prior to 360,
joule.
I will start. No, ma'am. No, sir. I will start from 120.
50 to
100.
100.
To be started with
50 to 100.
50. But now books are saying 200 is the correct joules to begin with, because the chances of patient getting converted to normal sinus rhythm are high if you start with only 200 joules. But prior to cardioversion, would you like to see something?
I left atrial any clots, or she should not have any thrombus.
Yeah.
Should not be present.
Okay. But since pregnancy is a hypercoagulable stage, So we should always have a doubt that she might be having LA clot. Okay. So
Yes.
whether the patient has been anticoagulated or not, that we should confirm, right? Before going
Yes.
ahead for cardioversion. Then during cardioversion, fetal monitoring is a must. So somebody
Yes.
should keep on monitoring fetal heart rate prior to doing cardioversion, right? Okay, go ahead. Now your heart rate is settled by medical management or whatever cardioversion. Then next, what you will do? What are your other goals?
Which monitors you have attached? You have not mentioned. Multipara, only you have mentioned multipara. In multipara,
Yes.
what you will monitor?
I will attach ECG lead, saturation probe, BP cuff, if in possible intra-arterial BP monitoring, then for CVP line, central line, a temperature probe, because I
Yes,
want to
temperature.
happen temperature probe. It is CO2 if I am giving general anesthesia, then it is CO2 monitoring I will prefer.
Why temperature you want to monitor?
I want to have normothermia. It is important for patient to maintain the normothermia, because hypothermia will lead to increased pulmonary vascular resistance, pulmonary artery hypertension.
It leads
Also,
to
it is
increased oxygen consumption.
increases oxygen consumption, and also detrimental to fetus, as it may cause uteroplacental uh, uh,
Insufficient.
insufficiency.
Okay, go ahead. What will hypothermia cause?
Sorry, ma'am.
Hyperthermia.
Hyperthermia.
That will also cause increase in the oxygen consumption. Okay, so we have to avoid both hypo as well as hypothermia. Now you go ahead. What are the other anesthesia goals?
Emergency. Important case of emergency as one नहीं important.
Anesthesia goals. First, you told normal sinus rhythm and control of ventricular rate. Any other thing?
Systemic vascular resistance, ma'am. Judicious IV fluid, and to maintain the adequate preload and systemic vascular resistance.
Very good. Very good. Any other thing you want to avoid?
Rising pulmonary vascular resistance, ma'am.
Rise in pulmonary vascular resistance. Any other thing you want to avoid?
Tachycardia and atrial fibrillation.
So that also you have told. Avoid giving any head low. You're not supposed to give any head low position to the patient, right?
Okay. Yes.
Okay. Go ahead now.
After that, contractility of the heart. We should not depress the heart by giving induction agents very fast.
Go ahead now.
Yes.
Give general anesthesia to the patient.
I will induce by rapid sequence induction with preferably injection intermediate and scoline by titrated dose only. Then intubation, and after baby out, I will give opioid for sedation and pain management.
Which opioid you will use?
I will prefer injection fentanyl or remifentanil, 2 microgram per kg dose. Also benzodiazepines, I can use injection midazolam, and also, sir, other multimodal analgesia.
And for maintenance of anesthesia?
Yes, sir, muscle relaxants.
Which muscle relaxant you will choose?
I will choose cisatracurium या vecuronium. Sir, I will avoid using atracurium or pancuronium, which causes tachycardia and histamine release.
Now baby is out. Now what other drug we are supposed to give, and why we should be cautious?
After baby out, tocolytic, uterine tocolytic drugs should be given, and I will avoid prostaglandin and methyl ergometrin and carboprost as they will increase pulmonary vascular resistance. Prefer oxytocin, ma'am.
Oxytocin. What caution should be used while using pitocin?
Pitocin causes tachycardia and hypotension. So I will give dose very according to hemodynamic.
It has to be given slowly because it reduces SVR, right? So that is why it has to be given very slowly. What other drug you will give after baby delivery? And why we are worried?
Your uterus is contracted. Now your uterus is contracted. So what will happen?
There will be auto transfusion and increase preload on the heart that will cause volume overload. It might cause
Will cause pulmonary. So how much blood is auto transfused? How much blood is auto transfused?
Sorry.
300 ml of blood is approximately
300 to 4. Yes.
300 to 500. Okay, so you would like to give Lasix. Any regional analgesia you would like to give for this patient?
Regional analgesia.
Yeah.
Yes, ma'am.
For post-op pain relief.
I will go for tab block, transverse abdominis block, quadratus lumborum block. This can be given. 30 to 50 ml volume we can give.
Tab block on one side or both sides?
Both sides, sir.
How much volume you will give? And
Total
concentration?
32.
Concentration?
Total 0.5% plain bupivacaine and
0.5%.
0.5% is not for analgesia, no? That is for anesthesia.
No, 0.125% or 0.125% to 0.0625% on both sides.
Right. Now, suppose this patient would have come earlier, right? Suppose, say, in the first trimester of pregnancy, and it was detected during that time, and her Wilkins score was, you can say, 8, 9. Barabar? So, what could have been done in this case? Because we know as the pregnancy advances, the severity of mitral stenosis increases and it goes up by 1 grade. So what should have been done in the second trimester of pregnancy?
If she is my elective case, then I will suggest balloon mitral valvotomy or percutaneous mitral commissurotomy according to Wilkins score.
Okay. So you know the procedure how balloon mitral valvotomy is done?
Yes, ma'am. I just read. I have not seen.
What are the indications of BMV in pregnancy in a pregnant patient with MS? What are the indications?
For a BMV, ma'am?
Yes, for BMV.
Symptomatic or symptomatic patient with NYHA grade 2, 3, 4 with severe, moderate to severe MS. without having any left atrial thrombus or clots, and without having any pulmonary artery hypertension associated. And valve morphology should be normal.
Okay. And how much should be the Wilkins score? I already told.
Less than 9, ma'am.
Yeah, it should be less than 9.
But
Okay.
pulmonary hypertension is not the excluding
Yeah,
criteria.
it is not.
Actually.
It is not an excluded criteria. Patients with pulmonary hypertension can be done.
Yeah.
Okay. Even with mitral valve area 0.6 to 0.8 also, we should give a trial of balloon mitral valvulotomy. Now you tell me, what are the advantages of BMV over MVR? MVR is mitral valve replacement. So what are the advantages we are offering to the patient by doing BMV?
In MVR, ma'am, they risk for mother and MVR in non-pregnant patient and mother will be the same, but it will be detrimental to the fetus. There will be neurological impairment in fetus.
Okay.
So we are off.
Fetal prematurity. Okay, and fetal mortality increases. Even maternal mortality
is high in MVR.
Any
That
other,
won't happen in MBMB.
It can happen in BMB also. But what is the other advantages? Other advantage of BMB over MVR?
Ma'am, we don't have to, the patient does not have to go for a cardiopulmonary bypass.
Yes, cardiopulmonary bypass and its detrimental effects. Okay, and it is less invasive compared to MVR.
MVR.
How the procedure of BMB is done? Can you tell me in short? And anesthesia part?
Transatrial procedure, balloon mitral valvulotomy is done transatrial.
They go via femoral route.
Femoral route.
They enter right atrium, then they do transseptal puncture, and they go towards left atrium to the mitral wall. They inflate the balloon. Okay, and that is how they do balloon mitral valvulotomy. Okay. Now, what are the complications of BMV? And before complications, how are what are the anesthesia concerns when a patient is posted for BMV?
Ma'am, patient if having patient is having mitral regurgitation, BMV can.
And in which trimester BMV should be ideally done, and why?
Now it should be done in the second trimester.
Second trimester.
It should be done in the second trimester. Why we are doing it in the second trimester?
To avoid radiation risk.
Radiation risk, so it will be there anyway in any trimester. Any other risk which we are avoiding by doing BMV in the second trimester?
When fetal embryogenesis occurs in the first trimester.
Okay, so we are avoiding that. That is why second trimester is considered to be the best period for doing BMV. Now, what are the anesthesia concerns or anesthesia management?
Ma'am, this BMV is done in an awake state, ma'am. With minimal dose of opioids are given. And this opioids, if it is given, if it is given in large concentration, then it will cause fetal bradycardia and also apnea. Fetal apnea apnea in the pregnant state it can occur, and which can also lead to aspiration in the patient.
So that is why it should be done under monitored anesthesia care. We have to keep everything ready for intubation because patient can become bad at any time point, right? And we should be ready with that. And only second trimester is not the only indication for doing BMV. If the patient is coming late, like in the third trimester, okay? So during third trimester, if the patient is presenting, which period we should choose? We have to choose the period judiciously. Which period should be chosen?
Before 36.
Yes, it should be after 28 weeks, right? Because that time, otherwise preterm labor and whatever the problems of prematurity are very high. So we should do it after 28 weeks after giving. What should be given to the mother? For fetal maturity, what is given?
Dex,
Yes,
steroids.
dexamethasone should be given for fetal lung maturity.
Fetal lung maturity.
Lung maturity. And then they go ahead with BM, because if any problem occurs, fetal maturity, for fetal maturity, we have given dexamethasone. And what are the complications of BMV?
It will increase if mitral regurgitation is there, then it will increase its.
So mitral regurgitation can occur during BMV. What are the other complications during BMV? There can be cardiac tamponade. Okay, the patient can go into any type of blocks. So all these things we should take care, and accordingly we should plan BMV. And for all BMV procedure, CVTS standby should be taken, because in any patient, the valve can rupture. Okay, and that acute MR is very poorly tolerated by the patients. Okay, immediately we have to wheel in the patient for doing cardiac surgery, that is MVR. Understood everything about BMV?
Yes, ma'am.
Yes, ma'am.
Now next, what are the indications for cardiac surgery in these cases?
Excuse me, ma'am. Meeting might end, so new link we have generated, so we will rejoin that.
Oh. After how much time?
Okay. 10 minutes. Continue, ma'am, please. 10 minutes time.
10 minutes time is there. So we will finish now within 10
Yes.
minutes. Okay, now whenever we are planning for, if the patient is coming in emergency, like last trimester, and she has got mitral stenosis, which is not amenable to medical treatment, not amenable to BMV. So only option with us is to do mitral valve replacement, right? So whenever the patient is posted for mitral valve replacement, we have to explain the risk to the patient and their relatives, the risk of prematurity, the risk of fetal, you can say premature labor and all those things we have to explain. And whenever possible, we should do C-section first, followed by mitral valve replacement, MVR, right? So if C-section is done first, followed by MVR, there are very less chances. The only problem will be, because we do heparinization, the problem will be of PV bleeding,
PPH.
that we have to PV bleeding and PPH, right? Uterus atony. So accordingly, we have to give all uterotonics, like this girl mentioned. We have to give pitocin, okay? And we have to check care of only pervaginal bleeding. But suppose if fetus is not mature and the patient has come early, and she is in failure, not at all responding to medical management, BMP cannot be done, her valve is totally calcified, cordae are fused, we don't have any other option other than doing mitral valve replacement. So we have to put the patient on cardiopulmonary bypass.
Bypass.
Yeah. So in bypass, few things we have to remember. The first and foremost thing is, otherwise bypass is a non-pulsatile. So in these cases, we should do pulsatile CPB, right? Then we should keep the pressure on the higher side, mean arterial pressure. Then we should keep flows also on the higher side. Why we should keep flows on the higher side? Because we have to maintain uteroplacental circulation has to be maintained. Then all the time we have to monitor fetal heart rate, or that fetoscope, something comes through. So throughout we have to monitor fetal heart rate, or otherwise there is something called as Doppler. So through Doppler we should always monitor uteroplacenta, and all the time patient's oxygenation should be good. There should not be hypoxia. There should not be this alkalosis should not be there, because all these things, they increase the risk of fetal prematurity and fetal drops. Okay, so all these things we are supposed to take care. Mean arterial pressure should be on the higher side, and pH should be maintained on the alkalotic side, because acidosis also reduces uteroplacental circulation. So all these things you should keep in mind whenever we are doing uh, CPB in a pregnant. CPB in a pregnant. Right? So that's it for me. Any questions?
Ma'am, there is only one question from the audience. Scoline should be used for induction or not?
It can be used. It is not a big contraindication. Scoline can be used, because if the patient has not, or in the preoperative period, if the patient has not received Lasix, you have all the electrolytes, there is no hyperkalemia, we can use scoline, because they are considered as full stomach. Now, otherwise, instead of scoline, we can use rocuron at a higher dose, 0.9 to 1 milligram per kg body. We can use that. Any question from Himani Ketki?
No, ma'am, I think you have asked all the all the minute details pertaining to the topic has been covered, and you have explained
Only
that
symptoms we could not cover, because I thought otherwise we will run short of time. So that is why symptoms.
Yes,
and in that also few symptoms we covered, minor symptoms.
Yeah, but majority of the query is like managing, giving patient labor analgesia and giving general anesthesia. I think that anesthesia management part was more of important for the students. So that has been covered very well. Yes, ma'am.
Still, Himani Ketki, if you have any doubts, you can ask.
Yes, ma'am, sure. So I'm, you stop your presentation then, Himani?
Yes, ma'am.
Now I request our Honorary Secretary, Dr. Anjali Borkar, ma'am, to propose the vote of thanks. Anjali, ma'am.
Thank you, Dr. Ketki. It was a wonderful discussion, sir and madam. You've carried out the case discussion so thoroughly and so patiently, covering each and every aspect of the case. Thank you so much. I really want to thank Dr. Shakuntala Basantwani madam and Dr. Sugandh sir for joining in and giving your precious time and teaching our students such a very important topic, which can come in their written examination as well as in their practical examination. Thank you so much, ma'am. Thank you so much, sir. I want to thank the presenters, Dr. Himani, Dr. Harshali. You have done a very good case presentation and taken a lead in this. We have been carrying out our first series of the online PG activity, the app series, and you are the first presenters of it. So thank you so much. I also want to thank the senior faculty members who have joined in today, Cham sir, Anjali Savargaonkar madam, Sangawar madam, Sudha Jain madam, for joining in and supporting our PGs. I would like to thank all our PG students who have joined in this interesting case discussion. I want to thank Ketki for so very well coordinating this program from the beginning and doing it till the end. Thank you so much. And also would request everyone to continue to join us for our upcoming app series, which we will bring in interesting cases for the PG students. Thank you so much. Long live ISA.
I would like to thank ISA Nagpur. Basically, I am a student of Sangawar madam. I am from Nagpur, IGMC.
Oh, so nice, ma'am.
Yeah, thank you very
Sangawar
much.
madam had joined. Yeah.
Yeah, I am madam student. I don't know whether she remembers or no. I am madam student. Yeah. Okay.
Thank you
very
so much,
much.
ma'am.
Yeah,
Thank you so
so
much.
much.
We can leave the meeting, ma'am, right? अंजलि मैम
रिकॉर्डिंग
Yes.
आपको आ जाएगा केट की
हाँ
रिकॉर्डिंग
yes sir
आपको क्या
हाँ सर आ जाएगा मुझे ये वो मैं शेयर कर दूंगी
ठीक है ना
यस सर आपका वीडियो मतलब ऑन करिए ना सर ओके सर
ठीक है
यस
थैंक यू
Thank you,
थैंक यू
Ketki.
मैम थैंक यू सर
Thank you. Thank you all.
Sugandh sir thank you so
Thank
much
you all. And good night.
थैंक यू
good night
गुड नाइट मैम
Night.